So someone wanted to know about the HIT test and the HINTS test. And you need to know about these even if you're an ophthalmologist, because it can mimic acute vestibular syndrome. So the acute vestibular syndromes usually go to ENT because they have nausea and vomiting and they have vertigo. And what we're trying to figure out is this a peripheral vestibulopathy or is this a central vestibulopathy? And in the acute setting, like in the ER, you're trying to determine whether this person has a stroke or whether they have a peripheral vestibular neuritis or labyrinthitis or some ENT thing. You cannot rely upon the ENT symptoms because they're both vestibulopathies. So they both are going to have vertigo, they're both going to have nausea, they're both going to have nystagmus. So this is where the HIT test and the HINTS test comes into play. So in a HIT, that is a head impulse test. It's kind of like the Dahl's head maneuver, which you're used to, which is a test of activating the vestibular ocular reflex, except instead of it being a slow movement to differentiate supranuclear from infranuclear palsies, it's a rapid movement. And what we should see is the eyes just stay on the target because the rapid movement is compensated by the vestibular ocular reflex. However, if you do the rapid movement and the eye has to make a corrective saccade, that is actually an abnormal HIT test. And believe it or not, for an ophthalmologist, an abnormal HIT test is good, because what that means is it's ENT. It's likely to be peripheral if you have an abnormal HIT, because that is an asymmetric input from the vestibular ocular reflex, and that can go to ENT. The dangerous one is central, and that's why you have to add onto the HIT test, you have to add the HINTS. And the HINTS is testing for nystagmus, and you have to test for skew deviation. So the presence of nystagmus and skew are what the ophthalmologist in the ER needs to know about an acute vestibular syndrome. And the reason it's important is these findings suggest that it's central. Now, both the peripheral and the central vestibulopathy have nystagmus, and so the nystagmus is going to be horizontal, but in central, it's going to be bidirectional. Goes to the right and goes to the left. But in peripheral, it's unidirectional. It goes towards the one side. And the peripheral does not cause skew deviation. So that's a hyperdeviation that's going to cause diplopia that cannot be explained by muscle or nerve. So if you have a positive cover-uncover test, you find the hypertropia, or the person's complaining about binocular diplopia, or we have bidirectional nystagmus. This is how the ophthalmologist can help in differentiating this. The HIT test helps us because if it's abnormal, that suggests it's vestibular from a peripheral lesion. And so a normal HIT test could be really great, there's nothing wrong with you, or it could be really terrible, there's nothing wrong with your peripheral system. And in the presence of bidirectional nystagmus and a test of skew, that is the HINTS test, that is central. And the reason it's dangerous is the CT and the MRI scan might be normal in the acute setting, and this person needs to be on the stroke service. So do not use the normal CT, which is very insensitive, and even a normal MRI scan is not as good as performing the HIT and the HINTS in the ER.